Okay. Hello, everybody. Welcome. My name is Andi, like Gandhi, but without the G, Kinsey, and you are here with us on Kicking the Bucket Live. And I'm so excited that you're here today. Kicking the Bucket Live is what we think of as a companion to the fiction podcast series. Now, you can follow the links below to go hear the series, and all of the topics that we're discussing are things that happen to the characters and in the story. So that's why we think of it as kind of a companion to the fiction podcast. But today I am very excited to be talking to both Jess Paul Amby and Megan Klein, who are both coming to us from, now we talked about this before, from UT Health Austin, and they are here. I'm going to get it exactly right. They are in the Mulva Clinic for the Neurosciences in the Comprehensive Memory Center. Did I get it? I got it right? Okay, excellent. So Jess is a clinical social worker, and Megan is a physician assistant. So welcome, both of you. I'm so glad that you're here. My alma mater, UT. I am going to get started. We're going to be talking today about cognitive impairment, what families can expect as it progresses, and new treatments that bring hope. I'll get us started off with the questions, but if any of our viewers or listeners have any questions, feel free to throw them in the chat right now and we will get to them or continue the conversation later on socials. So, Jess, will you get us started off? Will you give us just like a quick introduction about, who you are, what your background is, how you got to where you are today?
Yeah, well, hello everyone. And I first received a master's in cultural anthropology. So I was always interested in people and systems. And from there, I came to UT and got a degree in social work. And I've worked in hospice as a social worker, and I've worked here now at the Memory Center for almost 8 years. And I've worked at a couple different counseling centers. So um, that's my background. So I sort of have been on the path with people in different stages of dementia and also in end of life.
Awesome. Thank you, Jess. What about you, Megan?
Yeah, so I've been a PA for about 18 years now. Started my career in kind of later stages dementia in nursing homes. We then moved, and I took a different job working with individuals with mental illness and adult and geriatric psychiatry. Did that for about 10 years. And then we moved again, came to Austin, and took this position. And I've been here for about 3 years. And so this is a little bit different for me to be on the front side of the diagnostic side of dementia.
Did you both feel a calling to work with cognitive decline, or did you just kind of fall into it? Jess, what about you first? Sorry that we didn't plan that question, did we?
Well, I mean, I would say I definitely fell into it. I didn't have the intention going into school that this is the field that I would focus on. And my first placement, just like it's like almost the first or second week of school, I don't even know what social work is. And I got placed in hospice care. And I was like, that's a lot. And I really didn't like it. My first internship, and maybe it was just overwhelming. But then kind of, I think once I got more training, then and learning more about counseling and like processing these things and being able to help in that way, I was really excited about it. So it's sort of, I'm not surprised I found myself here just because uh, it's just it's a, I don't know how to put words to it exactly, but it's um, you're seeing people with different orientations, so you can't take anything necessarily for granted. And I think that's interesting.
Mm-hmm. Yeah. Okay. And Megan, what about you? Is the same thing? Do you feel something similar about how you see people at the different stages?
I was definitely, my passion is with older adults. So I felt that calling early on. And then that kind of, and I've been able to see them in different arenas. But I think I've always had that passion for older adults.
Yeah. My kids and I are always, we're like, or especially my daughter, she has like fashion on Pinterest of much older women. She's very interested in that. So okay. Um I feel like before cognitive impairment enters a family, we kind of don't really have a good understanding. So let's start at the very basics. Can you talk about cognitive decline, dementia, and Alzheimer's? What is the difference? Is there a difference? How can you just define it for us to begin with?
Yeah, I think it's important to think about this as a spectrum. If we think about, all of us in our 20s, there's no cognitive decline. We're operating at an optimal level. Oftentimes we might, we're still in school. We move down the road, we get to, 60, 65, and we might start to notice changes that are age appropriate. Where did I set my keys down? Um, and then further down the spectrum, we might see something that we call mild cognitive impairment. That is when we can see changes in memory and thinking on testing. Um, Often the individual is aware that there's a change in their memory or thinking. Um, but in this instance, in mild cognitive impairment, it's not yet affecting functioning. So they're able to take care of things at home. They're able to take care of their usual tasks, activities. Um, that memory or thinking isn't affecting their functioning. And that's kind of the big takeaway when we're thinking about mild cognitive impairment. And I'll let Jess continue down the spectrum.
So, yeah, dementia is an umbrella term. I mean, once we start to have difficulties with our everyday functioning due to our memory or thinking, that's when we reach the level of dementia. So, uh, what is causing the dementia? What is causing these changes in functioning? So there's under that umbrella, there's a lot of etiologies that could be responsible, like Alzheimer's dementia, vascular dementia, frontotemporal dementia. So sometimes people use Alzheimer's and dementia like in the same way, but that's the difference. Is really dementia is pointing to that we're at a stage that because of an issue with us neurologically, we're not able to function independently.
One of
Okay.
our
Oh,
one
go
of our
ahead.
physicians uses the analogy of ice cream. If we think about ice cream, there's a lot of different flavors. So dementia is the ice cream, and we have a lot of different flavors: vanilla, chocolate, strawberry. So there's a lot of different flavors of dementia. Um, Alzheimer's being one of them. It's the most common, so I think that's the one that we hear the most, and that term gets used the most.
Are practitioners often telling their patients which flavor they are? Or because I often hear that it's like, oh, yes, this is dementia. Does everybody always know like what their flavor of dementia is? Or
I mean, I'll be curious to hear what Megan says and what sometimes it's hard to know. Sometimes it's hard to know what is the specific flavor. And also, if we wait so long to get tested and to get a workup, all these different dementias as they progress can look more and more similar. And it's hard to know. It's much easier to kind of know what the cause is or what the type of dementia is when we get tested early in the process, because that's when these different types present more differently. What would you say?
excuse me.
Bless you.
Thank you. Yeah. I was trying to hold it in.
I would say to some degree we're getting better. We have more tools at our disposal to help us with the etiology. The other thing that we do is in our name is Comprehensive Memory Center. So we do testing, we do imaging, we take a really thorough clinical history. So we're putting all of these things together to try to arrive at the most accurate etiology. But even then, sometimes we can't. But I think that for the most part, we're able to educate, we're able to give our best idea of what we think is going on.
Okay, so then cognitive decline is what starts to happen as we age, and then when that progresses, it becomes non-functional, or you can't function as well, then it falls in under the umbrella of dementia, and then all of those different etiologies under dementia. Okay. Thank you for explaining that. I feel like we interchange a lot of the terms, and so sometimes we jump into discussing it and we don't even know which aspect we're talking about. So so now that we understand it, can you give us a quick breakdown of, and I know, like you said, it can take many shapes and forms, but do you have like can we summarize like a short breakdown of kind of how it progresses? Like how is our brain changing as we age? What's happening?
Yeah, I mean, I would say that well, one is like the most popular question often once somebody has a diagnosis is like, what will this look like and how long? And it is impossible to know exactly how long or how many years, from stage to stage. And I would say, like, in a summary, this is a global brain disease. In the beginning, generally you see more issues with memory loss or thinking, but still there, somebody's able to compensate around those things. Like, so when we have a whiteboard and we write things down and, we're still driving okay. So first it can be, just these changes in memory loss and thinking that we kind of identify when people think like Alzheimer's, they may identify with that. And then in the latest stage, like the later stages, it becomes more physical, so people have changes in their gait and they may shuffle and they may have falls, and they may not be able to coordinate their movements as much. So it kind of goes from, just this a change in thinking to also change in like our physical being, how that's going to change. So um, that's kind of what. Would you add anything to that?
I think we were talking about insight.
Oh, yeah. Yeah. So, I mean, an interesting point to me is that, often in a mild cognitive impairment, like an early stage of, let's say, Alzheimer's, somebody can be really aware that they're forgetful, that they're not remembering the same things. And if they have a family history, it can be very distressing to notice these changes early on. And so sometimes we do see people with a large amount of distress when they come into the clinic. And what's interesting with this, with particularly if we're talking about Alzheimer's, is that there's a term anosognosia, which means lack of insight, that our insight can wane, our insight can change over time. So our awareness of our memory loss, as we progress, as we become more forgetful, we may be less aware of it. And so we also may be less distressed about it. And that's a
Mhm.
pattern that we've seen, many times. So I think a lot of times people also think, well, as we see a decline in our cognitive ability, like with Alzheimer's, we're going to see, you know, mood decline. We're going to see people be more depressed or anxious, or we're going to see these things correlate. And that's not necessarily true. I mean, so we've seen people where maybe they're very distressed and very anxious at the beginning, and as the condition declines, they actually, you can see their mood improve. And sometimes, the mood stays the same. And sometimes, so it's not, yeah, that's really interesting to me, like when we think about progression.
And
I think
uh-huh.
I think what Jess and I do too in kind of a lot of the work that we do on the day to day is helping families navigate the different stages, the different phases, the things that come up during these things. Him from the lens of a caregiver, me from the lens of the patient and the caregiver, but just helping people navigate, because a lot of times they don't know what to expect. And our goal is to provide that education, and help people navigate, let them know what their resources are, let them know what's out there to help.
What are some of the common things that you tell them to expect, that coming, like what's going to come? Yeah.
I think from the physical side of things, prepping caregivers that the amount of assistance that they're going to eventually provide, from things that like meal preparation, medication administration, getting dressed, helping with showers, helping with brushing teeth. That just continues to increase over time, the amount of support needed for those daily activities. Um, and
And
then
that's
walking them.
because the decline and it gets to the physical point. Is that what you were talking about earlier? Okay. So,
Correct. Yeah.
uh, so then, okay, so that physical change, when we're talking about the memory, I've heard somebody once say that it's kind of like your bucket is getting full of all of your memory, and then the more recent things are what's kind of spilling out of the top. Do you feel that that's the case, or is it deeper, longer term, long ago memories that are disappearing?
I mean, I would say like a nice analogy that I've heard is like when we think about Alzheimer's is like a file cabinet. And in the beginning, yeah, we typically do lose more short-term memory and our long-term memory is intact. So we can absolutely name the movies we were watching like, 20 years ago and classic things. But kind of what we did yesterday might be more challenging. And so then over time, you see that kind of first it's just that very top shelf, and then you can see like being more forgetful of more recent memories. And then also it's not uncommon for someone to sometimes like identify um uh like their adult children for their siblings. um so you just have these changes that occur, that they're a little bit more disoriented in space, and more of their, if your short-term memory isn't there, then you could assume like, oh well, I'm this age and my siblings would be this age, and if we only have that part of the file cabinet.
Mhm. And is this specific to Alzheimer's, or is this does fall under the wider term, umbrella term of dementia?
I mean, it's more classic to
Yeah.
Alzheimer's, let's say that. Yeah.
Okay.
I mean,
Okay.
with all of these with frontotemporal Lewy body, it's going to impact all aspects of your brain at some point.
Hmm.
It's just with Alzheimer's, it's really impacts our short-term memory first.
Okay. So when you were talking earlier, I was thinking about kicking the bucket and the story. And in the story, um, they want to take charge of their end of life. So Dolores has Alzheimer's, and she doesn't want to get to the point where she doesn't remember her family, her people around her. Like that to her seems like a point that she doesn't want to continue living. Yet what you're saying about us not perhaps not caring or not being as much as distressed at the loss of our memories as we progress. Um, uh, I guess I'm thinking of all these things, like when we make our advanced directives, we're thinking about the loss of that memory and how distressed we are going to be. But if as we age, we become less distressed about it, where is there, like, how do you know how to do an advanced directive if you might be fine with what you think that you're going to be terrified about? Is that making sense? Sorry, it's all these
Yeah.
things are like going in my head. I'm like, wait, this is
Well,
connected to that.
it's like I mean, it was in there. It's a big ethical kind of quandary because it's like if we're um say we're 65 and we say, oh, well, this is how I live, this is how my brain is, and I wouldn't want to forget anybody. But then say we do get Alzheimer's and say we're 75 and the 75-year-old person with Alzheimer's is content and isn't distressed in that way and wouldn't say like, oh, I don't want to live or I don't, so then which person do we kind of listen to? And then, yeah, then also it's like, anyways, it's I think it's a challenging question.
Yeah. Yeah. I guess we all just have to go through it as we can, one at a time. What works for our families. Cool. Okay, so speaking of families and like the individuality of it, where in the process or at what point you were talking about resources, Megan? At what point can a family feel like it's okay to ask for help? Like, it's normal that this is really hard. It's a hard thing and there are resources. Where should one feel comfortable saying, yes, I do need help. I can't handle this anymore.
I think it's going to be a very personal decision, but the idea of reaching out, it should happen at any time. I mean, it could be in the very beginning, it could be smack in the middle, it could be towards the end, and it's a very personal decision because I think each caregiver is different in how they're able to support their loved one. And we talk about, sometimes we talk about placement. We talk about, if you aren't able to do this, would you want to go somewhere? Would you want to have somebody come to you? And sometimes it's not necessarily the individual with dementia that we're thinking about. It's what can the caregiver manage? How's the burden and the stress levels for the caregiver?
Yeah. I'm glad you brought that into play because it feels like we often leave the caregivers out of the equation and they are just as important to what's happening, because you have to find something that works for everybody and is sustainable for everybody, right?
Yeah, I mean, I would say like in our clinic, we take an approach where I mean, really, I just meet with families. That's what I do. And we meet with families even during the workup. And I would say like it's, once, especially if we have a diagnosis, starting earlier, because this is one, I think about this, when we think about dementia, it impacts this is a disease that impacts the family. So it's the person living with dementia, and it's also the family member whose life is changing and all of the demands of caregiving. So really kind of meeting with somebody or talking about these things sooner so that we can kind of build resources and supports and awareness. It's challenging. So having kind of the more support we can have, the better.
Do you encounter, or what advice do you have for individuals? So let's say it's an older couple and they're both still around, and one of them notices that their partner is declining and tries to talk to the rest of the family members who are maybe not living in the same household, and the rest of the family members, for whatever reason, are like, no, 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 mom's okay or dad's okay. They're not declining. Do you have any advice for how the person can get it across that there actually is decline happening and that they do need help?
Yeah, it can be really challenging. I mean, we have also, like, in grief, when we even, maybe other family aren't able to see that just right now, to see these changes, and when will they be ready? I mean, it's hard to know. I mean, we always encourage, like, having the family come, like, the
Mhm.
more family, the better, because the more support, the better. So sometimes, like, it's like, if we can take our son to the neurology visit, and kind of hear that firsthand, that could be helpful. And I think often once there's a diagnosis, it's like maybe families are kind of okay, more willing to kind of hear what's happening. Um,
Yeah, get the diagnosis. Speaking of diagnoses, since we only have a couple more minutes, do you have any things that you would like to share about new treatments? Like what new is happening within the field of dementia?
So in the last couple of years, we have introduced disease modifying treatments for specifically for Alzheimer's disease. Um, so these are the first medications that make an impact on the disease process itself. But it is important to understand that it doesn't stop the illness and it doesn't cure it. But what we're trying to do is um, preserve the functioning where the person is right here in this moment for a longer period of time. So we're trying to delay progression with these medicines. So I think these medicines represent an important start and first step in this process with Alzheimer's disease and getting to a cure. We're not there yet, but it represents certainly a first step. We're understanding more about these medications and who's a good candidate, who's not a good candidate. Um, we're finding that the earlier we intervene, the earlier we catch people in this process, that they tend to be better candidates, both from the outcomes, but also from the side effects. These medications have very significant side effects that have to be taken into consideration, and that's also what makes it hard as far as who can be a good candidate. I mean, it's a pretty limited number of people that actually are good candidates, but again, it's a first step.
Mhm. That's exciting. And so it's still under research or still being researched right now, right? Or
There are two medications that are available commercially that insurance is covering. So there are two out, and then there's definitely still research going on. Yeah.
mm, okay. So I feel like we've just hit the tip of the iceberg, and there's so many more things to talk about. But do you have any final thoughts that you'd like to share about, I guess, the most important thing that you could share with or a person would need to know before coming to you? What is it that you wish that they knew before they came to you at the memory center?
That's a good question.
I mean, we were talking before, and it's just like, um, one, it's just we're glad that they're coming in. A lot of people are afraid of coming in, but like Megan was saying, there's more options now than there were just a few years ago. Um, so that's what I would say is, and then as a family member, if your person doesn't want to come to the clinic, then it's really being directive and being clear, like this is what we have to do. Um, because yeah, it's important not only for the person to get the diagnosis, but also the family member to kind of understand what's happening.
Yeah, think it helps. Yeah. Megan, do you have thoughts or did Jess sum it up for you?
I think he summed it up nicely. I think he summed it's all about having a plan. How do you prepare for the future?
Yeah. And not being afraid. I love that. Don't be afraid to come in. So, well, thank you both so much for being here for a very, very quick conversation about cognitive decline and like what we can expect and where to find resources and not being afraid to find resources. If any of you want to get in contact with Jess or Megan, follow the link on the bottom of the screen. You would then follow you'd go to uthealthaustin.org, click to clinics, click to MULVA Clinic for the Neurosciences Neurology, and then cognitive disorders. And that will take you to where they are. Feel free to jump in and listen to Kicking the Bucket as well. Next week, we're going to welcome Dawn Delaloy, a spiritual advisor for Reflecta, which is a new technology that uses AI to turn memories of loved ones into a digital companion. So that's going to be really interesting.
Yeah.
Hope you can join us next week. Thank you again, Jess and Megan. We're going to sign off now. So I'm saying goodbye. We were so glad that you were here and we look forward to more conversations.
Thank you for having us.
Yeah. Okay. Till next time, our neighbors just down the street.